which will take place Thursday as well, 4 p.m. to 7 p.m. at the CHS courtyard. And it's okay if you don't know where these places are because that's where you're gonna go on a tour after this. We will have free pizza and giveaways at the student organizations fair, so you want to make sure that you attend. We will also have a welcome luncheon for APRN students and a Bachelor of Science student welcome on October 5th. Cool. How's everybody feeling? You good? Cool. Let's go ahead and let me pull this up here. Screen here. Yes, you sent me this one here.
Okay.
Yeah, I got it. Let me just read your intro real quick. Yeah. All right, moving on with the program. We have a very special guest today. Our keynote speaker for our program today, his name is Fernando Fierro. We're gonna go ahead and do the intros for this part of the program. He's the Assistant Vice President of Nursing Services at Altamed. He joined Altamed in 2018 and has more than 20 years of experience in healthcare. Mr. Fierro provides oversight for ambulatory clinical practice, as well as applying, evaluating, and improving those standards to ensure ambulatory clinical practices meet all regulatory requirements and organizational policies and procedures. He provides regional leadership for nursing and clinical support, which functions while working collaboratively with the administrative and medical leadership teams. Fernando Fierro earned his Associate of Science in Cardiopulmonary Sciences, Bachelor of Science in Emergency Management, and his Master's of Public Health from Loma Linda University. In addition, he also obtained his Master's of Science in Nursing from Western University. All right, without further ado, I'll introduce to you Mr. Fernando Fierro. Go ahead.
All right. Good morning, everyone. Thank you for the honor and privilege of allowing me to come here and share my story as well as my organization story, which is Altamed. But before I do, I'm going to tell you guys a little bit about myself. So this is a picture of me a long time ago. I was actually, and that's my oldest son. I was actually 20 years old there. I was in, take a couple steps back. I'm actually one of six. I'm the oldest in my family. I'm first generation American, first generation college graduate. I'm English as a second language. And so we weren't very familiar how to access the college road or that pathway. So I chose the military. I am an Army veteran. I served 3 years in the Army. Nothing medical. I was actually infantry. And at that, specifically a combat engineer, was explosives and demolitions. And then I cross-trained as a Cav Scout. At this time frame here, my son is 1.5 years old. He was telling me goodbye, which is always the hardest part when we separate. But I had also completed my first college class. It was at Kansas State University, English 101. So fast forward.
Yeah, that one.
Fast forward, the one in the center, the tallest one, this is his graduation from nursing school. He's now an RN and I'm an RN as well. So at this time, back here, neither one of us knew we were going to be nurses. So again, because I had him, I chose to leave the military so I can try the medical field. But again, had no idea I was going to be a nurse. And oops, wrong way. I'll get this. And here is in the late fall of 2019, graduate from his RN program. And then approximately 4 months later, we'd be put into a pandemic. So his first year as a new graduate was the pandemic as an ER nurse. in one of the hospitals that I used to work at, one of the ERs I used to work at. So he was working with my colleagues for the during the pandemic. So those of us who worked in the pandemic or tried to go to school in the pandemic, we know how tough that was. It was very hard on both him and myself, but with my experience and background working in critical care and also being in the military, we made sure to debrief after every shift. And he did really well. He had some hard days. There was a couple of times where he had to, when he told me about young parents in their 30s, 8 and 6 years, they're in their 30s. The wife was getting intubated. The husband, he was trying to talk to my son, and my son in Spanish was telling him what was happening to his wife. And his wife wasn't going to do well, and she ended up passing away to COVID. But he did ask, well, is that going to happen to me? And my son said yes. Well, not the passing part, because that hadn't happened, but he said, we're going to intubate you. And at that time, the father and husband said to my son, well, who's going to take care of my 8-year-old and 6-year-old who were at home by themselves? And so he quickly made arrangements to have him call and get family to sit there. Fast forward, those two did not make it. They passed. And that was a tough case for him. That one really hurt him deeply. But with the amount of debriefing we were able to do, he was doing fine. He's now currently working in San Diego, an ER Scripps Hospital, Chula Vista. And so this is my family now. I got my youngest, Vincent, there. He's a lot taller now. He's taller than me. He's as tall as his brother. And that's my wife, Angel, and then my son, Ryan. So Ryan, Vincent, and Angel, and that's my family. So that's a little bit about me. Professionally, I did my cardiopulmonary science degree. That is actually a respiratory therapy degree. So I was a respiratory therapist. When I came out of the military, I wasn't sure what I wanted to do. I knew I wanted to go in the medical field, but I wasn't sure how good I'd be around people or in medicine. So I did go into respiratory therapy, loved it, loved taking care of people. I just fell in love with it. And then we had a personal loss. My mom's passed away to breast cancer at a very young age, actually at 42. And I remember how loving and caring those hospice nurses were. And that's when I decided to go back to nursing school and become a nurse. So my career as a nurse spans from ICUs, critical care, ERs. I worked with both pediatric and adults as respiratory therapists. I worked with NICU patients as well as ER and critical care. I do have experience working in ambulatory care as well for IHP. So I've been very fortunate in my career to have multiple opportunities to continue to learn and experience the wonderful world of nursing and medicine. So on to my presentation. The learning objectives: define social determinants of health, or SDOH, and describe their impact on underserved communities. I believe you guys already had a presentation. And then describe the origin of federally qualified health centers, FQHCs, more commonly known as, and their comprehensive services for underserved patients. Identify key features of Ultimate Services, America's largest FQHC. So challenges to healthcare and challenges to health. Environment, in pollution and barriers to transportation, economic stability, unemployment, poverty, debt, education, language barriers, poorly funded schools, healthcare, lack of insurance, provider cultural incompetency, and inaccessibility. And then lastly, and not least, social community, immigration status discrimination. So social determinants of health are economic and social conditions that influence individual group differences and health status. Now I can tell you from experience that I grew up through all of these factors. So how do these socioeconomic factors play in human health? I really like this diagram because I don't know if how many of you have seen it, but the diagram for burns, it's the percentage of nines. And so clinically, that would tell you, depending on how much percentage of your body was burned, what your mortality morbidity would be. Well, that's how I kind of clicked onto this one because it's just as serious. So 40% of individuals' health is socioeconomic factors like, sorry, my eyes are not as, education, job status, family support, income, and then community. Your physical environment plays a factor on your health. There's several studies that show if you live about approximately 100 yards from the nearest freeway, you have an increased risk of asthma exacerbations or developing asthma. Health behaviors and healthcare. So challenges in healthcare. We all know the huge nursing shortage that we have. We've continued to have that. We've had that for some time. It got quite worse, and it's been exacerbated by the pandemic. It used to be when nurses, during the pandemic, what I saw in 10 years, nurses were seen in 1 to 2 years in the amount of mortality with the pandemic. And that takes a toll on nurses. And so now we have the factor that nurses are leaving the field altogether, which is very heartbreaking. And so we have that added on top of the shortage of physicians and providers, behaviorists, dentists, and especially people who are missionally aligned people. Multiple payers add complexity in delivery of care. For example, in our organization, not only are we surveyed by other regulatory bodies, but we're also surveyed and held accountable by 14 different health plans, which is quite a bit. Electronic health record would be a struggle in our environment. We are Epic. We use Epic. The top 3 are Epic, Cerner, Meditech. But for those smaller mom and pop shops who can't afford EHR, what are they using? Are they able to use EHR? And what happens to those large organizations when they get hospitalized? How are they able to access those medical records? So that too, electronic health record is a blessing. I will never want to go back to paper because we have saved lives with electronic health records. We've improved the quality of care with electronic health record, but it too can be a struggle in our environment. And an acute shortage of specialty and mental health services for patients with Medicaid or county-based coverage. Never more has this been highlighted than this from our pandemic. Has anybody heard of an FQHC here before by show of hands? Okay, a few, good. All right, nice, a little comforting. So the history of federally qualified health centers. They developed in 1950 to 1960s during the Civil Rights Movement. It was President Johnson's war on poverty. Dr. H. Jack Geiger, a civil rights activist, led the advocacy for health centers in medically underserved areas. He was influenced by community-based care in South Africa, which had brought about astonishing health improvements for its poorest citizens. In 1965, funding for the first 2 neighborhood health centers were approved in Boston, Massachusetts, and Mound Bayou in Michigan. What is an FQHC? It stands for Federally Qualified Health Center, provides comprehensive primary care and preventative care, serves more than 28 million people in 12,000 rural and urban communities across America, does not discriminate on the ability to pay or health insurance status, and is funded by the Bureau of Primary Health Care, the Centers for Medicare and Medicaid Services, and Health Resource, HRSA, Health Resource Service Administration. This is the checklist for being qualified as a FQHC. Got to be not-for-profit. Is governed by community-based board. 51% are patients. Delivers comprehensive primary care and supportive services. Serves as a medically underserved area in a health professional shortage area. Offers services to all persons through the sliding fee discount program, and has ongoing quality assurance program. Complies with HRSA site visit requirements every 3 years. Now that's the minimum. At Ultimed, we are also Joint Commission accredited. So we just had a Joint Commission accreditation survey. So we are regulated by both HRSA, Joint Commission, in addition to the 14 health plans. And if you're on our pay side line of business, also by CMS. The benefits of being an FQHC is Section 330 grant funds, fair reimbursement through Medicare and Medicaid, medical malpractice coverage through Federal Tort Claims Act, and access to vaccines for children, eligibility to receive a National Health Service Corps, J-1 visa physicians, loan repayment programs, eligibility for other expansion grants and federal loan guarantees. Now, earlier I had stated we had a shortage of physicians. So with this benefit here, the J-1 visa physicians, we are actually have physicians coming from Mexico to come practice primary care in our clinics currently right now, which is very exciting. Benefits of Improvement and the Protection Act, again. For PPS, you have bundled payment rate for every Medicaid patient, covers all whether insured or uninsured, offsets cost of all services that the clinic offers, and covers 80% of FQHC's cost of caring for Medicaid benefits. The PPS rate is the rate at which we're reimbursed, but it's also dependent on where the clinic is at, the patient's panel to the clinic, the severity and complexity of those patients. That also sets your PPS rate. So via the Medi-Cal example, if we were not an FQHC, a primary care visit would be reimbursed at $30 per patient, whereas being established as FQHC, indicating and stating that you're applying, that you are providing the minimum of that, which is that checklist for FQHC, you get reimbursed. We get reimbursed at $240 per patient. So financially, as for an organization, it's financially viable to be a federally qualified health center, but you have to meet those requirements. So not any private practice can just throw a sign out there, say they're FQHC, and then not provide the care they're supposed to provide. Which unfortunately, the reason why there are requirements for FQHCs is because these types of abuses have occurred, and it's the patient who ends up suffering at the end. So the FQHC difference, active involvement with communities. All of our clinics are currently embedded in the communities, and I'll show you some biomapping. We address circumstances that determine health, social, cultural, linguistic, economic, environmental, political. We're fortunate at Ultimed, our organization grew, our DNA comes from community activists from the 1960s. Actually, a lot of our founding members were part of the Brown Berets of East LA. And so we have a strong history of social advocacy and community support. Reduce barriers such as cost, lack of insurance, and distance. FQHCs generate $24 billion in savings for the healthcare system annually and provide care for 28.4 million patients. Currently, at Ultimed, we cover over 400,000 lives within the LA and Orange County areas. And then we increase access to timely primary care, reduce costly avoidable emergency department visits and hospital stays. Our goals: promote patient-centered, high-quality care, ensure providers always practice evidence-based medicine, address the social determinants of health, and foster positive work environment for mission-aligned physicians. These are actually our goals. I can't speak for all FQHCs. So this is the map I was telling you about, and then the stats we went over about how many FQHCs there are across the US. There's actually quite a few. Now, I was at a conference and right up in the Wisconsin area, I was speaking to a physician who also worked in FQHC, and we were talking about our patient populations. And by the end of the conversation, we came to a consensus. There was many more similarities in our patients than differences. Even though his were rural and ours were more in the urban, he still had to deal with food deserts, seasonal foods, education, lack of income, lack of access to care. Very similar to a lot of factors that we have to deal with as well. These are the FQHCs around Los Angeles. Just checking my time. So these aren't all Ultimed. Ultimed is embedded in there, but they're not all. And not all FQHCs are created equal. At Ultimed, who we are, this is the fun part for me anyways. We are the largest independent federally qualified community health center in the US. We provide high quality care in health professional shortage areas and medically underserved areas. Our employees reflect our patients in both culture and language. 80 to 85% of our employees are from the community. And so they display great cultural competence. This is our mission. Again, if you when you read the mission, you'll see where the roots of our organization are from, and that's from that social advocacy from the 60s, when in our East Los Angeles communities, we did not have access to healthcare. So we tried to take it on by establishing our own clinic. So our mission: to eliminate disparities in healthcare access and outcomes by providing superior quality health and human services through an integrated world-class service delivery system for Latino, multi-ethnic, and underserved communities in Southern California. Our vision is to be the leading community-based provider of healthcare and human services. So, and we follow the quadruple aim, which is improve physician experience, improve patient outcomes, lower cost of care, and improve patient experience. I had already hinted a little bit about this, our history of Ultimed. This is actually a picture of our very first Ultimed clinic before it was called Ultimed. It was the East Los Angeles Barrio Free Clinic, founded in 1969 by our CEO, Costello de la Rocha. Initially, it was a volunteer staff storefront operation. They did have a jar where they would take anything anybody can put in. But other than that, they did not charge community members for access to a physician and health care. Responded to the unmet needs of underserved and uninsured populations, primarily in Latino communities, and then was renamed Ultimed Health Services in 1986. Again, as I stated earlier, this is our scale today. We have over 400,000 patients. We've had over 1 million annual visits. We have more than 300 physicians, dentists, advanced practitioners, and nurses. Actually, our nurses alone are greater than 300. We're actually at almost 500 nurses. Our patient demographics: 82% are Latino, 50% patients are 19 to 64 years old. Greater than 50% of patients are below the federal poverty level. 18% of our patients are uninsured, 83% Medi-Cal, 17% of our patients preferred language is not English. And in fact, there's actually, if you look at that diagram, that's actually what our language, the different languages that we provide, because our patients require it. So our service, the service we deliver: primary care, pediatrics, family and geriatric medicine, women's health. Family and geriatric medicine is aside from our PACE program, which I'll talk a little bit towards the end. Actually, it's listed there at the bottom. Women's health, pharmacy, urgent care services. We have HIV services, hepatitis C treatment, PrEP and PEP treatments, dental care, restorative services, oral surgery, preventative services, examination, x-rays. Within our clinics, we try to house as many of these services all in one stop so that we minimize the amount of visits or places that our patients have to go and visit, because that is a difficult, as you guys have had the social terms of health presentation given to you all, you know that barriers to healthcare is either access, transportation, multiple visits. That itself can be a barrier. Behavioral health, individual psychosocial therapy in LA and Orange County. We do have a mobile health clinic, which we're growing those services out. And then lastly, but definitely not least, is our PACE centers. Our PACE centers have very strict criteria set by CMS. And it's one of our success stories of our organization. So this is PACE, which stands for Program of All-Inclusive Care for the Elderly. PACE was a name. We went to PACE after the federal government moved away from adult daycare centers. And a lot of that movement, and the reason for that from the federal government, was because we had organizations that were abusing and collecting funding for the care they say they were providing, but not necessarily that they were providing it. So the criteria for our participants in our PACE program are not, we don't consider them patients. They are, but they're participants. Their services for 55-year-olds. They're frail or functionally impaired adults up to an extent. So they do have to have some ambulation, but if they do have some neuro conditions, we do have resources in our facilities to accommodate and work with them, as well as PT and OT. We provide, in the PACE program, we provide medical, social, nutritional, rehabilitative services, primary medical and specialty care, prescription medications, basic dental care, and adult daily living health services, hospitalization or home care services, and transportation services. We pick up and drop off almost all of our participants to make it more convenient for them so they're able to participate. And we've come to the end. Our PACE program also is Joint Commission certified. We just finished our Joint Commission accreditation resurvey in August, a few weeks ago, and we had a wonderful, it's probably one of the best surveys we've ever had, so we're very excited by that. But brings it to the end of my presentation, and here at Altamed, is there any questions? I will say that at Altamed, we use a whole host of interdisciplinary team members. We use MAs, LVNs, and RNs. RNs are going to be one that we are actually growing out as California and other states is a little more on the financial side, move to an alternative payment model. Whereas historically, nurses were not paid for the care they provide. They were usually our care is bundled into the overall service. However, because we're trying to reach and really provide more appropriate complex care to complex patients, the APM model looks at what is the visit that the patient's going in for, and if they're coming in for a nurse visit, an RN visit, provided the documentation's there, that encounter will be reimbursed. So we're currently building that model out because historically RN visits and the care independently has not been reimbursed, but in this new payment model, it will start to be reimbursed as an encounter, provided that there's a proper documentation and the need for that patient care. So I just wanted to let you all know, because when I went to nursing school, there wasn't a whole lot of information on ambulatory care or what FQHC was, but there's this whole other world that it's a wonderful world to be a part of. And it's actually the gate, we are the front line before the hospitalization. So thank you so much for allowing me to come here and brag about my organization and a little bit about my life. I appreciate that. For those of you who are starting the nursing profession, I'm so happy for you all. I wish I would have started a lot earlier. It has been a wonderful profession. It has made me the person, the man, the father that I am today. So congratulations and welcome. And those for you who are going into advanced practice, thank you. We need you all, and nursing needs you, our profession needs you. So thank you so much. And once again, welcome.
Thank you, Fernando. That was great. Please give it up again for Fernando. Oh, amazing. Moving on with our program, we're gonna go ahead and split you up into groups. We're gonna go into our tours. So can we get our wonderful staff members come down here by program? How about, where are my BSNs, all the BS students? You're gonna go on your tour with Lisbeth and Farnaz. So if you'd like to start making your way out. Just the BS students right now.